people with cirrhosis have to be our highest priority. One, because they have the most need for therapy now, so we can prevent progression of disease, reduce the likelihood of complications, reduce the likelihood of decompensation, and reduce the likelihood of cancer. They are also, at the current time, the most difficult to treat. The patients with compensated cirrhosis should be our prime target for therapy because we can prevent decompensation, because they are the most significant group in terms of size of the patients with cirrhosis. Anywhere between 2/3 and 3/4 are compensated, because patients with decompensated cirrhosis either die or get transplanted. And so they're our biggest group. We have the best data. They respond well to therapy, not quite as well as non-cirrhotics, but certainly very well. And we can prevent further complications. All of the approved regimens are approved for patients with compensated cirrhosis, though there may be treatment considerations, either the use or lack of use of ribavirin or alteration in the duration of therapy. Patients with decompensated cirrhosis likely also would get a very high benefit of therapy because they would either not have recurrence of hepatitis C after a liver transplant, or potentially they could recompensate. However, we have very limited data for decompensated cirrhosis. None of the approved drug regimens are approved for decompensated cirrhosis, and some have no data, and the others have very little data. And most importantly, we have not yet shown that patients will recompensate. Some of the limited data we have with either sofosbuvir-ledipasvir or sofosbuvir-declatosphere, which is not yet FDA approved in the US but is available in Europe, have shown that we can eradicate the virus and that there is some improvement in liver function. Unlike for hepatitis B, where we've shown patients could improve to a point where they come off the transplant waiting list, we don't have that data yet for hepatitis C. We have lower response rates and not a real established track record. So for decompensated cirrhosis, I think at the current time, treatment should be in a clinical trial wherever possible, and certainly in the hands of an experienced treater, usually a transplant hepatologist. The good news for people with HIV Hep C co-infection is that co-infection is no longer a predictor of lower response to Hep C therapy when HIV is well controlled. So for patients with well-controlled HIV, we treat them with the exact same regimen and duration that we would use if they were mono-infected with just Hep C alone. And the efficacy appears to be the same. Now with HIV, we do have to deal with the drug-drug interactions between their antiretroviral medications and the HCV medications. But once you choose a regimen in which the interactions are not problematic, and that varies based on the HIV regimen, it appears that you can use the same duration based on whether they're genotype, subtype, if appropriate, their prior treatment history, and the presence or absence of cirrhosis that you would do if they were mono-infected with Hep C alone. And one should expect an equivalent efficacy and safety profile. Patients with end-stage renal disease have a high burden of hepatitis C. This is because of several factors. Transfusions prior to the screening of the blood supply, an increased risk of renal disease in patients with hepatitis C, and a high proportion of high-risk groups, meaning people who have higher prevalence of hep C, persons of color, Hispanic Americans who have higher rates of both hep C and significant renal disease. Interferon and ribavirin were poorly tolerated in patients with end-stage renal disease, and thus many of the patients have not been treated. Currently, sofosbuvir cannot be used in patients with a GFR under 40, but can be used in patients with mild and moderate renal impairment. The regimen of paritaprevir, ombitasvir, and dasabuvir, the so-called 3D regimen, is hepatically cleared, and no dose adjustment needs to be made for mild, moderate, or severe renal impairment. However, that regimen has not been approved yet for patients with end-stage renal disease. It is the regimen that many of us are using in patients with ESRD because it is the only treatment option where we feel we can use it safely. If ribavirin needs to be used, there is an FDA-approved dose for end-stage renal disease of 200 milligrams per day, but it has to be used with great caution. It is hopeful that as newer regimens come out that are not renally excreted, that we'll have new data, both for the currently approved regimens that are not renally excreted, and perhaps for sofosbuvir as well, if we can find an appropriate dose, as well as for regimens that are currently being developed. For example, grazoprevir-elbasvir, a protease NS5A combination currently in clinical trials, is being tested in end-stage renal disease.